Nice. At the moment, we will see it streaming live. All right, so it looks like we are streaming live, so great. Hi, I'm Carrie Kratzer, coming from the Seattle, Washington area, and we want to welcome you to our Trisomy 18 panel, a medical panel, and we want to recognize today is Trisomy 18 Awareness Day, so timing is great. We appreciate all these gentlemen who have joined us this evening to bring some great information to you. And so, we hope you've had a great day. You've been wearing your blue. And make sure you got, we're going to be recording this, but have paper and pen someplace to take notes, because just listening to the opening as everybody's been coming in and settling and planning their approach, I feel like I've been in a master's level course. So it's pretty fun, and we're going to get some great information. So without any further ado, I want to turn it over to arguably the world-renowned expert on Trisomy 18. No pressure, John. He is the founding medical member of SOFT's board, friend to SOFT, always there for us. John, let's go over to you. Go over to Dr. Carey. Dr. Carey, over to you.
Thank you, Terry. Can you hear me okay?
You're fine.
Sound okay? Good. So I would like to introduce my colleagues and panel members. I'm going to introduce them on the frames that I can see, so it might be different than what everybody can see in the audience. But to my left on my frame is Dr. Glenn Green, who's a world-class pediatric otolaryngologist at University of Michigan, Mott Children's Hospital. Thank you, Glenn, for coming. Down in one corner, Dr. James Hamill, now in Western Michigan, cardiac surgeon, well known to all of us. And then Dr. Marty McCaffrey, who's a neonatologist at University of North Carolina, a colleague of mine for a number of years. Thank everybody for coming. And then Dr. Shaji Menon, my still colleague, but used to be with me at Primary Children's, now is at Penn State, pediatric cardiologist. Steve Braddock, also my friend and colleague of many decades, was a geneticist at St. Louis University. I would like to say that every one of my colleagues online here is actually a published author on some topic in Trisomy 18 and in Trisomy 13, and has a deep interest in our children with these conditions. So there we had many outstanding questions. It is truly going to be impossible to answer all of them, and even answer all of them from one particular parent. But I tried to cover ones that I thought would end up discussing many of the important issues, particularly in management, but also in genetics. And whatever we don't cover, I'm going to do my best to answer them with the help of some of my colleagues over the next week or so, but we'll try to answer all of them, even if it's by email. So I'm going to start with the first question from Meredith. And Meredith says, my daughter Rose is 6 years of age. Her heart diagnosis of double outlet right ventricle and tetralogy of Fallot was fully repaired by Dr. Hamill in 2018. She was 6 weeks old, and she flew from California to Omaha. 4 days later, she had full repair. Her heart had a leak. He shared how it would respond and grow. And maybe we could see the 2/3 of the year later, we could see the benefit. She's 6 now, and her heart works wonderfully. Her last echo said it looks stronger than ever. Could her physical activity, how can she manage her exercise? I'm sorry, I didn't say that right. Her heart is doing so well. Is this luck? Is this because she's small? Her leak hasn't caused much stretching. Is there an ideal situation that helps repair a heart of this sort so well? So I don't know if Jim, if you'd want to jump in at this particular point. There's a second part of the question I'd like to pose after that.
Thank you, John. I'm quite happy to be here tonight. First, congratulations on 6 good years with Rose. So that's really gratifying to hear. The type of repair that she had, the heart defect that she had initially, includes a malformation of the pulmonary valve. And so when she had her complete repair, we do not end up with a normal pulmonary valve that's going to grow and not leak. And in most patients with tetralogy of Fallot, we have to watch very carefully because over the course of the next, say, 4 years to 14 years, many people do have dilation of their right ventricle because of the back leakage of blood. I haven't seen her last echo, but it sounds like she's doing fantastically. And so as long as that's the case and the right ventricle isn't changing, we may not need to do anything. I don't think that we know what the very long-term outcome will be for children with trisomy 18 and tetralogy of Fallot, especially given that many of them have pulmonary problems that lead to it being more difficult for blood to go forward into the lungs, and that might make that back leakage worse. So I think a high level of suspicion and observation would be a good idea. But if she's doing well, then I think that we're most likely in good shape for now.
Thank you, Dr. Hamill. The second part of her second question I'm going to read because I think that Dr. Midden might want to address this with you. But so she asks, is it still the belief to go sooner than later for repair of pulmonary hypertension? I'm sorry, for repair to avoid pulmonary hypertension. So is it still the belief to go sooner than later for repair to avoid the pulmonary hypertension? Seems many people with VSD are still waiting and watching.
Yeah, I think, okay, and good evening, everyone. It's really a pleasure and privilege to be part of this meeting. But to answer the question, we know for a number of years now that babies who are born with either trisomy 13 or 18, they develop pulmonary hypertension, which I mean fixed pulmonary hypertension earlier than patients who do not have trisomy 13, 18, or for that matter, trisomy 21. So when we say early, we are talking about 4 or 5 months of age rather than 6, 7, or 8 months of age. So yes, typically trisomy 13 and 18 kids with a large shunt, meaning by blood going from left to right side of the heart, they undergo surgical repair a little earlier compared to those who don't have trisomy 21, 18, or 13.
Dr. Hamill, any
Go in on
additional
that,
comment?
John. If I could jump in,
Sure.
When she says watching and waiting, I think that is, of course, every heart and every child is different, but that is sometimes a concern that I have, is that our standard approach when a baby has a big hole in the heart is that as their lungs mature and they get more and more flow going through their lungs, they start to show us the symptoms of heart failure, and that's when we operate. But my experience has been that many of the children with a big VSD in trisomy 18 start to develop these changes that Dr. Menon is talking about early. I think that is clear, and they don't always ever go into this overflow heart failure, and the resistance just continues rising from there. And so patients who don't have their VSD closed early on may be kind of okay as their lungs become more and more damaged and it's harder for blood to flow through, the impact of the VSD becomes less. And so it's, in general, I'm still very much in favor of early operation. And I think that each child has to be looked at by echo usually, but sometimes with catheterization to determine is the resistance low to begin with? Is it high to begin with? If it's high to begin with, does it look like it's actually coming down, or is it just going to stay there? And then this all has to be taken into account with timing and decision making.
Thank you. And I think that sometimes in the past decades, there was kind of a feeling of, well, perhaps the infant with trisomy 18 is going to die for other reasons. Maybe we should kind of wait and see to see how they're going to do. And I think we're addressing that that probably is not the way to go, since we know from Dr. Green that when we used to think they were going to die for other reasons, some of those reasons are reasons that we can now take care of. So, and that'll maybe come up in the discussions. But the second question, second questioner is Marissa, and her question, I think, right from the start is an important one. How do you know when the medical intervention you can provide would actually hurt them, assuming our babies, more than help them, based on the newer information we have these days that we are using? So in other words, how do we know that the intervention is better than not doing something? I think I sort of look at this as a, a very long discussion of when the benefit outweighs the risk, of whether we're talking about surgery or some intervention. Then just like any baby, we would move forward with the intervention. Other comments from my colleagues?
Yeah, John, this is Marty, and welcome everybody. It's great to be with you all. I would say it goes back obviously even further than that. It goes back to prenatally and decisions being made about delivery and what you do in the delivery room. And I think when you're coming from a place where the traditional thought has been things like something like trisomy 18 is quote unquote lethal, we start asking these questions. I think what we've learned from the literature and the work that's been done by all the people on this call here, but many others, is that these babies are impossible to predict generally until after they're born. I think we really don't have a good sense of what's going to hurt or be over intervention until we get a chance to really see the babies and evaluate the babies. And I would say even that the ultrasounds that we do prenatally are not always spot on. It's very often that I'm dealing with families now that are being told their babies, once they have a prenatal diagnosis of trisomy 18 or 13, being told very commonly their baby has a hypoplastic left heart. And then the baby is born and the baby never got the memo, or there was some miraculous cure, which I don't doubt that can happen sometimes. But I think what we need to do is really look at the individual baby. And it goes back to what you're saying, John, throughout the course in the neonatal unit or throughout the course of their life. It really depends actually on the procedure or the intervention that we're contemplating, and then talking about that individual risk benefit. But I think the problem is we're coming from a place of tremendous bias where we have in the back of our minds that these babies have a lethal or a very, very life-limiting condition, which, by the way, I think we're all life-limited on this call and perhaps out in the audience. So I think it's difficult to know that until you see the individual baby and you can sit down and talk about what that individual baby's characteristics and issues are.
I agree very much. I think that if we have arrived at the point where we're discussing risk-benefit ratios for a particular child based on his or her individual findings, then we've come a long way, because the academic teaching for decades was that there is no benefit. There can be no benefit. There can be nothing good can come of this, and so everything that you do is wrong. And I do think that many practitioners are moving beyond that, and the work done by the other members of this panel, I think, has helped people to understand that there can be benefit. That it requires a careful consideration of the family's goals and their wishes, and what kind of values they place on different outcomes. So individualized
Thank you.
care, I think, is the key.
Shaji, I wanted to ask you a question to pick up on something Marty said. In the last less than 2 years, I've been involved with 2 families, one in Utah, in which the diagnosis of hypoplastic left heart, underdeveloped left side of the heart, was raised but not fully there. And then when the baby was born, they didn't have hypoplastic left heart. But because it was raised prenatally, it actually colored a lot that went on in the last 10 weeks of the pregnancy, when in fact, as Marty implied, at the time of birth, there was some underdevelopment of the arch, but it wasn't what we would say as full blown. Do you have any, as someone who's worked in the fetal echocardiography field for years, can you clarify my concern there or my question?
Yeah. So, over the last 20 years working in fetal cardiology, I can tell you that hypoplasia or smallness of the left side of the heart is one of the hardest diagnoses to make on a fetal echocardiogram. The reason is, as a fetus, the left side of the heart is not seeing a lot of blood flow. In fact, a lot of the blood bypasses the left side of the heart and go directly to the body. So left side of the heart often looks small or underdeveloped on a fetal echocardiogram. So not just in trisomy 18 or 13, even in babies who don't have trisomy defect, some of these babies have been diagnosed with hypoplastic left heart, while after birth, their left heart looks much more favorable. So I think, in borderline cases, in some cases, it's crystal clear. There is no question the left heart is really, really small. But in borderline cases, we should clearly wait till the baby is born and a normal circulation, a postnatal circulation is established to make that decision. I have had, opportunity to take care of multiple kids who were labeled as hypoplastic left heart who go on to have 2 ventricle circulation. So this can happen in trisomy or not in trisomy, so especially in borderline cases. So it's really critical to make that assessment after the baby is born when a normal circulation is established or postnatal circulation.
So thank you, Shaji. And Marissa had another question, but we've answered a lot of her other questions. I think I'm going to go to a third question, which is by Danielle. And her question, I'm going to respect her wishes and read most of this, but I will probably paraphrase some of it. So my daughter, Daniela, was born at 42 weeks at 6 pounds last October. We didn't find out until that day that she had health problems, so no prenatal diagnosis. The doctors were suspicious she had a genetic issue because of her abnormalities, but the diagnosis wasn't made till later. She was born with pleural effusion, which is fluid in the lung, and she had tetralogy of Fallot, which we've heard about already. The doctors said she was 35 weeks, but there was, that's all. They told me that they could probably do open heart surgery when her heart and lungs made the normal changes babies got used to after adapting out of the womb. She had a large VSD with her tetralogy of Fallot, but they were concerned about getting her stable on breast milk feeds. And along the way, she actually developed chylothorax, which is the fluid along with actually some fatty material from the diet in the lung, but it cleared up relatively fast. She didn't have any other issues and seemed to be doing well, was able to drink some breast milk from a syringe. But at 23 days of age, she developed an apnea episode, had a cardiac arrest, and she wasn't able to be resuscitated. The doctors said that they had done everything, that the parents had done everything they could, but of course they were disappointed they could not bring her home. She lived in the hospital a total of 23 days and got back to her birth weight. They seemed to treat her very well and they treated her with value. We took it day by day. But I do hear about heart surgery very on, and I know there are different types of surgeries. My question is this: if I would have pushed for heart surgery so soon, if they could have helped her. So the question was, both parents were wrestling with this issue with what had happened. Then she had the arrest and died, and they wondered perhaps before 23 days with tetralogy and a large VSD, could they have pushed for more surgery? Should they have pushed for more surgery?
Would you like me to jump in on that one?
Please, Dr. Hamill, thank you.
So the first, these children have a wide spectrum of defects. And one of the difficulties that develops in our parent community is not knowing who to trust or if you can trust anything. And so normally you need a lot of trust to work with your cardiac team, because what's right for one child is totally not right for another child. I think, I mean, we don't know all the details of your child's case exactly. And by the way I should have said at the beginning, I'm sorry for your loss, and I admire your bravery for taking part in this forum and giving us something to talk about. You said that there was tetralogy of Fallot, and without going too deeply into the details, that typically is a balancing kind of a defect where there's a VSD and there would be too much flow into the lungs and it would hurt the baby, except that there's also the tetralogy, which is an obstruction to flow into the lungs. And so it's a lot like having a successful pulmonary artery band. So I think it's very unlikely that your child's heart function was a major contributing factor in the baby not making it. And I would be quite surprised if we had felt that there was a benefit or a need to operate at 3 weeks.
Thank you. Anyone have another comment to add?
The only thing I would add is typically a heart surgery that is required soon after birth is in a case where there's a critical lesion, meaning by either there is really decrease of blood supply to the body or to the lung. And usually these are stabilizing surgeries. The definitive surgery is usually reserved for when they are a month or a couple of months older. So, you know, as Dr. Hamill mentioned in this case, it's unlikely that the baby's demise was, you know, could have been, I mean, that trajectory of events could have been changed by offering an early surgery, because, you know, VSD often we wait a little longer to perform surgery.
Thank you. So I'm going to have another question that's also related to heart and surgery, brings up other issues, brings up seizures. And then I'm going to probably switch kind of our themes after that. So this is from Sobia, if I'm saying her name properly, and she's actually from the United Kingdom, where Dr. Menon trained for some of his time. My baby girl was born October 31st of 2023 with full trisomy 18. At birth, she had an ASD, a PDA, and large VSD with irregularly shaped valves, common heart defects in trisomy 18. The most recent cardiologist report in January says the PDA and ASD have nearly resolved and the valves are not concerning, so that now she primarily has her large VSD and it needs repair. We're in the UK, and we're still fighting for her to be considered for heart surgery, subject to approval by a panel after respiratory and ENT reports, which are still pending. Her SATs have been up or down. Recently, she's been home. Her oxygen requirements have increased. At birth, she was in room air for 3 weeks, but then it increased through January. Last week, after a short stay in the hospital following a cold, her oxygen increased to 0.5 liters. I'm hoping for her not to need any more oxygen. The other suggestion was shunting due to the VSD. She's been on diuretics since January, but no other meds. So please, can you advise if increasing oxygen needs is part of the trisomy 18 diagnosis due to her growth or due to her shunting? Is there any other reason?
Well, here the devil is in the details. It is possible that the saturations have fallen because because there is some other obstruction to pulmonary blood flow. But the most likely reason for saturations to fall is that the resistance to flow through the lungs is getting worse, or higher anyway. And so less blood is going through the lungs than through the body. And some of the blue blood that should go through the lungs is going the other way through the VSD and mixing with the red blood and going out to the body. And so again, there are multiple explanations, and they could have completely opposite recommendations. But it would be a very concerning finding, having a saturation that's low at 4.5 months already.
I'd like to,
Please.
can I just jump in here? So first of
Please,
all,
Glenn.
I'm just really glad to be here and be able to talk with such a distinguished panel. I've really grown to appreciate and love the families of kids with trisomy 18. Now have many children that are now school age that I'm personally taking care of and get to see on a regular basis. And that's really delightful for me to see. And the main thing that I've noticed as far as improving the outcomes of the children has been addressing their airway obstruction. And desaturations are very typical for kids that have tracheobronchomalacia. And it typically, in a typical kid that'll appear 2 to 3 months of age, markedly worsens with colds, results in increasing oxygen saturations and sudden episodes of death. And there's interactions between the hypoxia of the airway obstruction and the cardiac hypertension that exists. And I'm not sure fully how they interact, but I think that at least the respiratory obstruction can at least contribute to some of the pulmonary hypertension, the increased rates that are seen in trisomy 18 kids. But I would strongly suggest for any kid that's having desaturations with trisomy 18 that they get a sleep study ASAP. That will distinguish between obstruction and central apneas, and that can be sorted out and the amount of oxygen be titrated in an appropriate way that might not be apparent otherwise. And particularly in a kid that is getting worsening with colds at about this age. That's a classic presentation for obstructive sleep apnea with airway obstruction in trisomy 18 kids.
So Dr. Green, on that line, not just you, but the entire panel, the next part of her question is concerning, actually. I'd be interested in people's response. Sometimes she cries so much she can have episodes where her eyes roll back, she turns gray or even blue and becomes stiff with her arms trembling, and sometimes floppy with no response. Is this shunting? Could this be seizures or part of her diagnosis of trisomy 18? Giving her facial mask oxygen during the episodes does help, and she comes back in less than a moment. So I was also thinking, as you were talking, Dr. Green, this episode that is described, I wasn't sure if that actually could possibly be obstruction.
It very much could be obstruction. That's what the sleep study helps to distinguish. Is it obstruction? And that seems to be highly suspicious for something like that. These brief events with severe hypoxia that respond with oxygen, that's a classic presentation. But there's other spells too. It can be hard to distinguish between that. This is a classic problem with trisomy 18. Is it's easy to say it's one or the other, when it could be actually a combination of all three. And so it's really working up all of these. So it's getting an EEG, getting a sleep study, and getting your cardiac examination to be able to distinguish which of these it is, because the interventions are different based on what it is.
Yeah.
Right, so sleep study, electroencephalogram for seizures, and then cardiac reevaluation. Shashi, did you have a comment?
Yeah, I mean, I'm on all these years, I'm yet to see a child with trisomy 13 or 18 who does not have some amount of airway obstruction. It is almost universal. I think, in my opinion, it is almost criminal to not evaluate a baby with trisomy 18 and 13 for airway obstruction and have a sleep study. That's one thing. Second thing is, these obstructions typically tend to get worse when a baby is upset or crying. And also, when a baby is upset and crying, it increases the pressures or resistance in the lungs. And that make the shunting from right to left more and making the baby more bluer. So these findings are pretty classic for a combination of airway obstruction, worsening pulmonary pressures, causing this combination of events that look like a blue spell. So I think every baby should have a detailed evaluation, whether they have cardiac surgery or not, to make sure they don't have an upper airway obstruction. It should be part of the initial evaluation. Pretty much it's universal to have some amount of airway issue and causing some pulmonary hypertension.
Thank you, Dr.
And-
Menon.
And
Go
that's
ahead,
a
Dr.
great,
Reed.
I just want to say
Go
that
ahead.
that's a great point that's made, is that the interaction between these things. So if you don't have the cardiac reserve that you otherwise have, and then what would normally be a tolerable level of airway obstruction becomes intolerable. And the same thing with seizures. Hypoxia can cause seizures to happen that otherwise wouldn't happen.
Thank you. And it relates to the question of seizures. I actually had talked to Kelly and Terry today about posting 3 papers of general interest for a lot of the themes that came up, and one of them is seizures. I helped work on a study last year that was published in the American Journal of Medical Genetics about seizures. Personally, I haven't seen seizures very much in the newborn period, but we do see them. In fact, sometimes what's called central apnea is seizures, as Marty has frequently reminded us. So, but certainly I think seizures should be considered because they're still a possibility. And of course, as Dr. Green just said, the interaction. So I think that,
John,
yes,
all
please.
of this is relatively new thinking, especially as far as the airway. And you have to give a lot of credit to old Dr. Green here for what he's taught so many of us, that these babies do have obstructive apnea. And, I didn't know this 10 years ago. I mean, I was still telling parents that, well, your baby's not breathing, it must be central apnea. And we would hear the phrase central apnea, and that was a death sentence. That meant that your baby's brain couldn't even control breathing. And, we hoped maybe some good things would happen, but they're not going to happen. And I think a lot of docs still have not gotten the word on obstructive apnea in babies with trisomy 13 and trisomy 18. I think it's very prevalent in both of them. And I so agree with Sashi. I mean, I think it should absolutely be part of the workup and the evaluation for these kids. Sleep study, and I think airway eval as well, just to get a sense of what's going on down there. But when parents hear central apnea, they should be thinking apnea means not breathing, but there's 2 big cans of potential causes for that. So one is central, and we've talked about seizures, can also happen with brain malformations, maybe, can also happen with prematurity. So if you have a trisomy 18 baby who's premature, they might have apnea prematurity, just like the premature baby in the next bed. And the other kids are the ones that Glenn has mentioned, the babies with obstructive apnea and collapsing airways. And then for Jim and for Sashi, I really think there is some connection here, as we're all alluding to, between obstructive apnea and worsening pulmonary hypertension. I think when you get CO2 retention that's chronic, and you get babies whose pH might be 7.4, but their CO2 is 75, and their base is, adjusted up to 45. I think that has some impact on the pulmonary blood vessels and the vasculature, and increases the predisposition to increasing pulmonary vascular resistance.
I wholeheartedly agree that that's important. Absolutely. and it's always everything. It's always the heart, it's some shunting, it's some degree of inflammation, it's aspiration, even if silent. John, I think you understated the impact that your paper on seizures is going to have, because the connection that you demonstrated between seizure and apnea is, I think, very important. I think that in our cardiac surgery literature, many people are looking for seizures in infants who've had heart surgery with or without trisomy, and finding them in a surprisingly large number of babies. And they can be silent. And it really makes one wonder how many of these episodes of apnea may be related to seizure activity in the brain, which doesn't lead to the typically recognized shaking and muscle activity that would catch the attention. But very, very important that airway is evaluated, all the things are evaluated.
Hey, John.
Yes, Steve. Please.
Just, I mean, first, I also am thrilled to be listening to all these distinguished opinions and already learning even more than I thought I knew. Two things I would want parents to know, though, and you and I have talked about this extensively, is, central apnea that everybody worries about, first of all, is usually a thing in not just the neonatal period, but really by the time you're out of 3 months of age, people shouldn't be thinking of central apnea causing the kids problems anymore. So if somebody's physician is saying, a 6-month-old is having apneic spells of short central apnea, they need to be looking for other stuff. That's no longer the time period that we're really expecting to see so-called central apnea. And the second, in reference to the sleep studies, which I wholeheartedly agree with, but everybody needs to remember that a sleep study is not a sleep study. So if your local place only does adult sleep studies, please don't try and hook a child with trisomy 18 or any other pediatric patient for that matter to try and get a reasonable reading. It really has to be done by someone or an institution that's used to working with kids, for one, and for a lot of our families. And this goes for trisomy 18, it goes for Down syndrome, it goes for lots of other things. If they're in rural areas with difficulty with access, it can be very hard to get adequate sleep study done. And so that's just another barrier that we have to figure a way to get them over.
Yes, thank you. I think changing some of the themes a little bit, Valerie had a number of great questions, and we've answered a lot of the pulmonary hypertension and cardiac ones, but she also asks, she doesn't mention her child in particular, but she asks, and Dr. Green, you might see if you can address this, what could we do to reduce obstructive apnea without surgery?
That's a great question. And this goes back to the first point, which is how do you weigh the benefits and risks of different types of interventions? And a lot of that is based on knowing and awareness of the outcomes of where these kids can end up, and being aware of the outcomes for the family, how having a child with trisomy 18 getting older affects the family, and how having a child that has a tracheostomy, how that can really affect the family. And it's a lot different than somebody might expect. And so there are people that are like, oh, I don't want to have any surgery because I don't expect my child to have much longer to live. And I think if we change our awareness, then we might choose to have surgery, or what type of intervention we might want to have in a different way. So just saying that, now I'm going to go back and say, what kinds of things can we do without surgery? The thing that's done in the neonatal intensive care unit is to give a RAM, or high pressure oxygen, through the nasal cannulas, or give endotracheally intubate, put a breathing tube in. These are things that keep kids with trisomy 18 in the hospital and stop them from going home. And that's in the neonatal period. And so the best way of getting a kid home is to deal with the airway obstruction so that those other interventions aren't needed. Now, in an older kid, a child that's 3 or 4 that has obstruction, and you don't want to have surgery, then a lot of times you can get substantial improvements by just using oxygen by nasal cannula. And that's different than neonates, where it's a different deal for children that are under 1 than for children that are older. And so the key is to get the sleep study, verify that the breathing is okay with the oxygen, that you're not just suppressing the breathing by giving oxygen, and then evaluate it in the context of any cardiac defects as well. And then in older kids yet, CPAP. This is more kids that are like 5 and older. Then the kids can wear CPAP masks. And kids with trisomy 18 are way more tolerant of having a mask on their face than most kids, just from being able to tolerate having something on your face and moving around too much. And the other problems that kids will typically have, that a typical 5-year-old will have, that make CPAP almost impossible, but it's a lot of times very doable in a kid with trisomy 18.
Thank you, Dr. Green. And Valerie has a lot of different questions in different areas, and just in our attempts to focus, she does ask a question: is it really real that trisomy 18 have more risk to have cancer? And Dr. Braddock, if you'd pick up on that question, topic that you have written about.
Yeah, it's a great question, and it's one that's been speculated about for years before I became involved with trisomy 18 and trisomy 13. Yes, the simple answer is yes. Children with trisomy 18, we believe, or I believe, do have an increased risk of certain cancers, and that's increased over the typical population, but the risk is still relatively low. So, if we estimate based on prior work actually that Dr. Carey had done, and he and I calculated out all sorts of, fractions to come up with this, we think that the 2 primary tumors or cancers that people with trisomy 18 are at risk for are called hepatoblastoma, which is a tumor of the liver, and a Wilms tumor or nephroblastoma, which is a tumor of the kidneys. And the incidence that we calculated for a Wilms tumor is about 1% risk for children with trisomy 18 to develop. And hepatoblastomas, based on published reports, are more common. So it's above 1%, but still, probably still less than 3% overall, or 4%. And the reason we don't know the exact numbers are because of the nature of the condition, where if a child were to survive the neonatal period and later pass away with trisomy 18, most folks would decide, oh, they died, your baby died, they have trisomy 18, this is what happens. And nobody would have done autopsies or other studies looking for other reasons why that child may have passed away. And they may well have had, a tumor that had not been diagnosed or was not noted because they have other severe health issues. So we feel that as the rate of kids surviving longer is going on, we're going to see increased numbers of tumors. But it's only been there's been other tumors reported sporadically, but only those 2 have been consistent in causing, in the literature and in our experience. What we recommend for families is a tumor, if the family wants to do so, I recommend a tumor surveillance protocol that would include having an ultrasound of the entire abdomen every 3 months until the child's at least 4 years of age. And also to have a blood test for a tumor marker called serum AFP, or alpha fetoprotein, every 3 months until the child's 4 years of age. After 4, we change from doing the blood test and worrying as much about the liver traditionally to just looking at the kidneys themselves. Now, I used to stop this. I used to recommend doing the liver until 4 and then stop the kidneys around 7 or 8, because that's the same protocol we use for a lot of other genetic syndromes that have increased risks of tumors. However, I'm aware of several families, or at least one family, who were doing the surveillance, stopped it, and at age 7 or 8 developed or was diagnosed with a hepatoblastoma. And for the last year, I've been trying to think through this and how to revise these criteria. And my best thought is that I'm going to start recommending that everybody continue the complete abdominal ultrasound surveillance probably until age 9 or 10, just based on the one aged child that was older and we missed or was not picked up by the regular surveillance. That's a lot. That's a lot of ultrasounds. Ultrasounds are generally benign, but that's a lot of trips to hospitals. That can be a lot of blood work every 3 months. But I think this is the only way that we really get onto this for looking for other issues. It brings up the follow-up question that hadn't been asked yet, but if you do have cancer, will somebody treat it? And as this audience knows, and as we've talked about finally being able to do heart surgeries and aggressive surgeries there, the first time I came to our oncologist and said, hey, I want to treat a child with trisomy 18 who has a hepatoblastoma with chemotherapy and major surgery, I got a dumbfounded look in response. But I think we need to, as with everything, talk about to our families so they can make informed choices about what the risks and benefits are. And, we followed a couple of kids here in St. Louis that one we've treated for a hepatoblastoma, and she's now 10 and has been healthy remission from that. One with Wilms tumor, who's now 11 and also is doing well at this point from that standpoint. But we've also had other children that have had tumors that were not candidates for either chemotherapy or surgery. And that was very difficult. But as I said, we had to look at the big picture, what's best for that family and get the family involved, what's best for their child to go through. So bottom line is yes, the incidence is at least 1% for Wilms tumor and higher, slightly higher than that for hepatoblastoma. I think the numbers may go up if we start to do more surveillance and if children pass away for reasons that aren't otherwise understood, like they didn't have a major cardiac event. People think about looking to make sure that they did or did not have intra-abdominal mass.
Thank you, Stephen. It reminds me that the two of us do have to do those revision of the guidelines and publish that in the appropriate place.
We were supposed to do that last week, John.
So staying on the theme about the liver, Catherine asks, is jaundice and high bilirubin more common in trisomy 18 infants? Has anyone looked if treatment for jaundice results in better neurologic outcome? So in regards to the question of jaundice and high bilirubin, in general, the Omaha group that Dr. Hamill has worked with closely, the neonatologists there actually published a paper 2 years ago that showed that bilirubin of the what's called conjugated form, that is where the enzyme had done its appropriate job, did occur higher in trisomy 18 and also in trisomy 13. But it tended to resolve with time. It does turn out that infants with trisomy 18 do have a low but higher risk for a problem with the biliary tract that actually blocks the bilirubin. biliary atresia probably occurs in less than 1% of children with trisomy 18. I've not heard of it in trisomy 13. So yes, increased bilirubin does occur in trisomy 18. Most of the time, it resolves on its own. Sometimes it's secondary to total parenteral nutrition. Barring that, it'll usually resolve. If it doesn't resolve for an older infant, the problem of the biliary tract, biliary atresia would be considered. So thank you for the question, Catherine, because it's important both in sort of normal events.
John?
Yes, please.
Children, Stephen, children with trisomy 18 have also been reported to have a choledochal cyst in their livers, which is in the biliary tree. It's not atretic, but a cyst has formed, and that also can be associated with jaundice. I don't recall if I've seen that reported in trisomy 13, but I know I've seen it in trisomy 18.
Hey,
Correct.
John.
Thank you. Yes, please.
I would say it's very important to distinguish the two types of bilirubin. So we see what you described, the conjugated form, but for the folks on the call, we get the unconjugated form. That's the common bilirubin we see in a newborn baby. And that bilirubin in particular is not generally at a much higher level than you would see in any other baby. But as John and Stephen point out, both 13 and 18 babies with trisomy, absolutely direct bilirubin can be an issue. And my thought would be they should be evaluated just like any other baby. There should be consideration given for things that may not even be related to their trisomy, but not weighted on. Things like congenital viral infections and other types of disorders, but also ultrasound, as you say, Stephen, to look for choledochal cysts, or to do at least try and screen, John, for biliary atresia. It's not necessarily the best test for that, but those things should be done.
Thank you. I can see we only have 4 minutes left, but we did start 3 minutes late. So I'll take anyone who has to leave on the hour can of our audience, and I hope my colleagues can stay on for an additional 3 or 4 minutes. But there were a number of genetic questions. I thought we would at least address them. Each of them are complicated. We can answer some of the questions. Brianna asks, how do you go about providing care to a trisomy 18 child if the child has partial trisomy 18? Do you put them in the same category as a typical full trisomy 18? So I'm going to attempt to answer this, and my genetics colleague and friend, Dr. Braddock, he can jump in as well. So in using the word partial trisomy 18, we're usually talking about having an extra copy of some, or maybe all, most of the long arm, the so-called Q arm of the 18. Partial trisomy of the short arm does not cause a syndrome of very much clinical or medical significance. I won't talk about it more. But partial trisomy 18 can range from having about a quarter of the end of the long arm extra to a half or almost the whole long arm. So children who have partial trisomy of the bottom third or half have parts of the Edwards syndrome, but they don't have what we would call the Edwards syndrome, and they usually do not have the same concern of risks for survival. They do have an increased frequency of heart defects that can be dealt with, but usually because they don't have the same mortality issues. Usually children with partial trisomy 18 of a lot of or part of the 18q are not looked at in the same as full trisomy 18 and are not usually have the same kind of, well, if somebody is going to say, okay, we're going to treat them a certain way, they're usually not treated that way. Of course, all of us on this call are not advocating for being treated with trisomy 18 any differently than any other child. Rather, we should be treating with the defects. So partial trisomy 18 depends on what is extra. I don't know, Steve, if you have anything else to add
Yeah.
about that.
No, I agree with you completely. And I think the statement I was going to make was actually the last part you said is, and with respect to the person putting the question is, we should all treat the child for the symptoms and the problems they have, not the number of in their chromosomes. And so whether it's partial or whether it's complete trisomy 18, you know, the treatment plans I try to push are for what the problems that are medically affecting that child are at that point, and that I try to convince my colleagues to look at the same way rather than how much extra is there or not.
That's an excellent point. We shouldn't promise to treat everyone the same. We should promise to develop a treatment plan that's completely individual, takes into account their needs and family's wishes. I was just going to ask if either you or John, with the many families I talked to, simple question that perhaps you could explain for our audience. I hear the words mosaic and partial used interchangeably, and they're very different.
Is that the question?
Yes, can you just clarify the difference?
Oh, I was gonna say, I agree with you. They're different. They're very different. So partial trisomy 18 or partial trisomy of anything is, as John was just describing, you have duplication or triplication really of just a part of the chromosome versus mosaicism, which means you have some cells that have 47 chromosomes, an extra 18 in this case, or an extra 13, and some that have the normal complement, 46 chromosomes. And everyone always asks me for if their baby has mosaicism, because they have hope that that means that they'll have a better outcome if not all of the billion cells in each of us has the extra chromosome. And my response always is that it depends which parts of the body have the extra chromosome. So if there's a major heart defect, I'm going to assume that the heart has trisomy 18 in it. If there's, if your skin has an extra chromosome, I don't really worry about it. It's not going to, it still works like our skin's supposed to work. So it depends where that is that determines the outcome, not whether you're mosaic or not. And in effect, what I tell all our families that mosaicism is great, but in the big picture, the only place that matters for most conditions is in here. And I've yet to meet a family that's asked me to do a biopsy of their child's brain to count the chromosomes. And trust me, that's one thing I will not do if you would ask me that. But that becomes, the ultimate spot in terms of what effect is something going to have on somebody's, at least on their cognitive development moving forward. We may all be mosaic. We just don't go checking each other for it. John, you may have a more eloquent way to put that than my sort of Missouri side.
You said it well, and of course, what we're talking about now would be an entire lecture in a master's of genetics course, whether it's genetic counseling students or someone getting another degree. So excuse us for oversimplifying all the complicated genetics. But I think I'm just going to close with there were two families who asked a question, Christina, and I'm excuse if I don't say this properly, Donaji, who both asked the question, is there any way to prevent trisomy 18 from happening? And Donaji, if I said her name properly, could trisomy 18 prevented while still in the womb? So the first question is that we don't know any way to prevent trisomy 18, or for that matter, trisomy 21, or for that matter, trisomy 13. Even though there are many colleagues who have spent their careers working on what causes that extra chromosome to occur, either before conception or maybe even in some circumstances after conception. So we don't actually know any way to prevent. It is a accident, if you will, or an event that occurs, usually, as I mentioned, before the egg and the sperm have united. As far as preventing while still in the womb, the answer is that we don't have any way to do that. But theoretically, there was a paper on Down syndrome about 10 years ago where they actually showed in a person with Down syndrome that they could turn off the extra chromosome in the cells. I have never seen that work go anywhere. This is all theoretical now. This is all out in the abstract. I haven't seen that heard of very much. Maybe Steve could comment if he would. But now with all of this gene editing work that's going on, but of course, we don't do gene editing in embryos. That's not considered ethically proper at the present time. But theoretically, if we could turn off the extra chromosome, and there was the technology to do gene editing in utero, it might be theoretically possible, but I certainly don't expect that to happen in decades if it does happen. But so the last question being one that's highly theoretical because it's important because so many parents ask both of those questions.
I would say, John, that, and it refers to the same study you're talking about, that we know of a prominent researcher who in the laboratory is trying to do that in an animal model to turn off, it was for Down syndrome, but to turn off that gene. And you and I both have asked that person multiple times, could this work for trisomy 18? And we've gotten nowhere with this. The real issue, though, again, is for the question, once the baby is in the womb, once development is occurring, there's already so many cells by the time you realize you're pregnant that it would be hard to turn that off in all the cells. And in theory, so that and to make sure you only turn off the trisomy, the 18th in all those cells, not some other critical chromosome or something. And so I think it sounds simple in diagrams. You know, we start with sperm and egg, they fuse, and that doubles and doubles. But I think it's by the time somebody realizes they're pregnant, it's hard to imagine that how many cells are already developed and are already sort of pre-programmed. And it's exponentially more than what the diagrams you ever had in embryology class.
Right. So thanks, Steve. Thanks for the clarification. I think we still did go even more than 5 minutes past the hour. And I really want to thank all of my colleagues and associates for joining us this evening. And you could see how many questions we have printed. I made an attempt to organize and cover the common themes, but we really only covered about half of what was in the text. So I didn't know if Terry and Kelly wanted to come on to make any closing comments or closing points.
Again, we just want to thank everybody for being here. We really appreciate that you gentlemen always agree to give us this time. And I know that our families are very appreciative of just being able to listen to this discussion, and it's just so insightful. So thank you from the bottom of our hearts. And I think Terry and I at this point have a few drawings for prizes because it is Trisomy Awareness Month and we do love to give away things. So if you want to stay for our drawings for prizes, you are more than welcome, but we do understand that your time is very precious. And so if you need to leave, we understand that as well.
But we also give you prizes, so there's that.
You're going to do the drawing now? Is that what it is?
We are, because we're still live on Facebook and we have a lot of viewers right now. So,
well, are we eligible to win?
Absolutely.
I'm going to sign off. Thank you, everybody.
Thank you so much.
Thank you, Dr. Hamill.
Dr. Hamill.
I figure I'm not going to win Mega Millions tonight, so maybe I'll win something here.
No, promise you'll get your gears.
all right, Terry, are you going to share your screen so we can see the wheel of
set up here? Yes, I will. So for those of you that have entered our drawing, we're still getting to share. We did not give away at the end of the week, so I think we probably need to do 3, Kelly, is what we need to do. And Barb's not here to tell us not to, so there's that.
Perfect.
Right, so here we go. Oh, all righty. You're seeing what you need to see there?
Absolutely.
Fancy.
There we go. All right, here we go. We do. There we go. And away it goes. Who's going to be the lucky winners tonight? We're really excited about how full our wheel is this year. All right. Nina Witz, I'm guessing Nina Witzel. Nice. Let me grab a picture of that.
Nina, if you can hear us, if you are on with us right now, if you could give your name and address to the page or send it to Barb Van Haraway, we will be able to get your prize to you.
In a message, don't post it on the page.
Oh, and yes, in a message. I apologize.
Well, all right. So, okay, we're going to go ahead. We're closing. We're going to leave her in for the grand prize at the end of the month. And let's do it again. All right. Sarah Kennedy Curtis. Again, in case you weren't listening, what Kelly said, message the page or one of us with your name and address so that your prize can be sent to you. All right, one more and then we'll call it a night. Everybody get on with their evening. All right. Jane Wright, yay. We can probably track her down, but still, Jane, in case it's updated, let us know. Congratulations to our winners. Barb will have a package off to you here in the next, very soon. She's pretty on the spot about it, but in the next couple of days. And our next event that we'll be doing live, and Dr. Braddock, you get a prize package just for staying with us.
Absolutely.
Barb, remember that. And so we just appreciate everybody being here with us. Our next event live is the 24th. On the 24th, which is next Sunday, a week from Sunday. Or is it this next Sunday coming? I've lost track. It's the one coming.
This Sunday coming.
Yeah, is our Angel Remembrance event. So for everyone out there, we'd love everybody to join us as we remember our angels. If you are an angel parent and you'd like to recognize your child, everybody needs to register for the event. But when you come to the event, you want to make sure it's going to be on Zoom. You want to make sure you have a candle so that we can go out to you. You can say your child's name and you can light that candle. The links for signing up for that are on the Facebook page. They're in email, on Instagram. You'll find it if you go to the page and look. So we just appreciate everybody being here. Kelly, were you gonna say something?
I was going to say that we will be having another medical panel discussion like this for Trisomy 13. You are still able to submit your questions for that one. So get your questions in so they can be answered by our medical advisors.
And that post is showing up fairly regularly on the page as well, so you shouldn't have to dig too far to find it. So again, we appreciate everybody being here. Again, to the whole panel for being here and taking their time. We are just so incredibly blessed to have such knowledgeable and caring doctors to help keep us informed and watch over our kids. So with that, we want to tell everybody good night. Have a good one. Bye-bye.